This audiocast is brought to you by the Vasco da Gama movement at www.vdgm.eu. This interview is hosted by Sarah Regon and Haris Lizidakis. We are very pleased to have with us Professor Jan de Maeseneer. He is the chair of the European Forum for Primary Care, and in half an hour he is going to give the visionary speech in this year's Vasco da Gama Preconference. So, hello, Professor. Could you tell us please something about yourself?
So I'm 59 years old, I'm married, I have two children, one is an oncologist in training and the other is an engineer, and I have 5 grandchildren. And so,
wow.
yeah, that's the way they're all very young, between 0 and 3 years old. So I started my career doing work in Rwanda, working as a volunteer for some months in Rwanda, in a health center over there, and that shaped really my ideas about what I wanted to do in the future. So then I came back to Belgium and started to work as a general practitioner in an underserved area in the city of Ghent in Belgium, with a lot of deprivation, also multiculturality. And we started there something new, a community health center. In Belgium we had the fee-for-service system, and we still have, but we switched our payment system for our patients, going to a capitation system and a patient list. So that made a very accessible center, and nowadays we are caring there for 6,000 people. We started in 1978, and today, so in 2011, we're caring there for 6,000 people. We have in the team general practitioners, nurses, social workers, dentists, dietitians, health promoters, and then also assistants, that receptionists and this kind of stuff. Yeah. So quite well organized. All the people are employed by an NGO. So, and we contract with the health insurance, and we receive a fixed amount for the patients according to the age. We have now a problem with the capitation system because it's not enough tuned to the needs of the patients. It's only in taking into account age and income and not morbidity. So what we now are negotiating with the insurers is to have a capitation where we have a capitation based on the needs, the health needs of the patients, the social indicators of the patients, because that will respond. Also, the multiculturality, which is an important problem. In the community where I live, we take care for people from more than 60 countries. So every consultation is a journey around the world. The first patient is coming from Tajikistan, then you have somebody from Turkey, a Belgian patient, somebody, and so very multicultural, which is of course a burden on the workers, but it's a very, very, very interesting kind of work.
I think that's
very challenging.
That's what you're going to talk about in your visionary speech.
Okay. And the other thing is that we have a lot invested in community-oriented primary care. So not only taking care of individuals, but looking at the community, and apart from the individual diagnosis, making a community diagnosis and try to find the upstream causes, and that are the social determinants of health, in order to address the real problems of the people. So that's what we try to do. And looking back at more than 30 years of my career, what for me was the most important, probably I meant a lot for many individual people, and that was okay. But on the other hand, the main important thing I think we could contribute to is that we have put our community on the political agenda, and that the city of Ghent has invested to improve living conditions of the population, thanks to advocacy that we did with a lot of others, and thanks to the organization of all the stakeholders. Every 3 months in our local community we meet with 40, 50 people that are the stakeholders of the community, that is the police people, that are the teachers, that are the healthcare workers, the providers, and so on. And we make a community diagnosis, and we bring that to the political level. And I think for a doctor it's very important to take this kind of community diagnosis and the advocacy role.
Absolutely.
The other thing is, of course, training the next generation. We are a training complex for our university, for Ghent University, and for the Department of Family Medicine and Primary Healthcare as well. And the other thing that the last years was very influential for me is that we tried to start up in the last 15 years training family physicians in Africa, starting in South Africa, and then now East Africa, and now we have already 20 countries where we try to help people to train family physicians to work in the primary healthcare settings in Africa. And we have some small projects in Latin America and in Asia as well. So that's
really global health.
Yeah, that's global health.
That's global health.
Yeah,
Yes,
right.
it's global health. Yes.
And what about your role in the European
Forum,
primary,
Forum for Primary Care.
Yeah.
I'm the chairman of the European Forum for Primary Care, and we really want there to look at health systems. And we try to bring together, on the one hand, the transitional countries, on the other hand, the Western European countries, and also to try to build a common European concept of primary healthcare, which of course reflects the values of Europe, which is the humanitarian values, and we try to really make sure that we are not going to fall into the trap of the fragmentation that nowadays is really a threat to healthcare. What you see more and more is that diseases, and especially non-communicable chronic diseases, are treated in vertical disease-oriented programs, diabetes program, a hypertension program, and so on. This is, of course, a problem because people have multiple diseases. Very often, once they are 65, 75, 85, there are 2-3 chronic conditions. So you have to integrate that. If you have vertical programs that are not integrated, this will lead to fragmentation of care. The other thing is that there is a high risk of inequity by disease because access to certain of these packages is determined by having the diagnostic ticket. And today, for instance, in our country, a patient with hemiplegia, you know what it is, due to a cerebral tumor, has much more care because he's got cancer than a patient that has the same problem due to stroke. And that's the inequity by disease. And we should be very careful if we organize the care in a vertical way that our good intentions to make care accessible for the patients with that diagnostic ticket will not spoil the equity principle and make an equity inequity by disease. And so nowadays I'm very active also internationally in the Network Towards Unity for Health, which is a network of community-oriented, problem-oriented and very socially committed institutions for training of health professionals. And I think that social accountability, not only of our profession, but of our training institutions, is really a topic that we should address if we want to look in a global way to health and health systems.
All right, excellent.
Okay.
Thank you.
Thank you very much. We look forward to hearing now your
Presentation.
speech. Thank you very much.
It's a pleasure.
This audiocast was brought to you by the Vasco da Gama movement. For more interviews from the Wonka Europe Conference, visit us at www.vdgm.eu.